Hello, everyone. I'm Jennifer Wheeler from the National Conference of State Legislatures, and on behalf of NCSL, I would like to welcome you all to today's webinar, Cost-Effective Investments in Children's Oral Health. We would like to thank the Pew Children's Dental Campaign for their support of this webinar and other activities at NCSL around children's oral health. After our presentation today, there will be a question and answer session with our speakers. Please note that you won't be identified when you ask a question, nor can other participants see what you have typed. You may participate by typing your question into the chat box on the lower right-hand corner of your screen. The PowerPoint presentation and an archive of the webinar will be available on the NCSL website next week. Now I would like to turn the webinar over to our moderator, Senator Judy Lee from North Dakota. Please go ahead, Senator Lee.
Thank you. I want to welcome every one of you to the webinar today. This is such an important issue, one that we've certainly been addressing in my state of North Dakota, and I'm confident that you have as well. And I think that the information that's going to follow here will be very helpful to all of us. I am pleased to introduce our first speaker, Shelley Geshen, someone I've known for several years, and I know she's a real advocate and expert in this area. Shelley has directed the Pew Children's Dental Campaign since September of 2008. Prior to her work at Pew, she has served in senior positions with National Academy for State Health Policy, which is where I have worked with her as well on occasion, NCSL, National Conference of State Legislatures, of course, the Southern Governors Association's Infant Mortality Project. In April of 2011, Ms. Geshen won the Public Service Award from the American Association of Public Health Dentistry for dedication to health prevention throughout her career. She served on the Institute of Medicine Committee that issued the 2011 report titled Improving Access to Oral Health Care for Vulnerable and Underserved Populations. Ms. Geshen has a bachelor's degree in English from Cornell University and a master's degree in public policy from the University of California at Berkeley. Please go ahead, Shelley.
Okay, thank you very much, Senator Lee, and thank you to my former colleagues and current colleagues at the National Conference of State Legislatures, and thanks to my colleagues here at Pew for helping to arrange this. So I have to say that when I first started at NCSL, I worked for a man named Dick Merritt, who some of you may know or remember. And when Dick interviewed me for the job, he said, "Are there any issues you won't work on?" And I said, "Yes, I won't work on dental, and I won't work on long-term care." And the reason I said that is because I thought that dental was a problem that very few people understood, and nobody really much cared about it, so it was really hard. It would be hard for me to make a difference on it. But over the years at NCSL, the issue kept surfacing, and as a person who has spent her career working on issues and programs that affect low-income moms and kids, I ended up realizing that I needed to work on it. So little by little, I did reports or worked it into meetings or hosted sessions on it in amongst my other work, and there is a tremendous audience for this issue, and I've been very lucky to be able to focus on it here at Pew. So today what I'm going to focus on is cost-effective investments for in oral health that state legislatures might want to consider. What our campaign at Pew does from our headquarters in Washington is invest in partnerships, both national and state partnerships, so that we can help promote policies that will improve oral health for children. There are a number of things that we work on. We work on prevention, such as expanding community water fluoridation, which for those of you in states with high fluoridation rates, you may not know this, but fluoridation is a very big issue, and you can't take it for granted. There are a lot of rollback attempts, and it's hard to make progress on that issue. We also work on sealants, promoting sealant programs. We work on financing, and then we work on workforce. So in terms of cost-effective investments, the first thing I want to talk to you about is a way not to spend your money. Some of you may have noticed a report that we issued earlier this year called a costly dental destination, hospital care means that states pay dearly. We noticed over the last few years sort of a trickle of state reports about the number of people showing up in emergency rooms with preventable dental conditions. So we collected them, and we also looked for and found national data from the Federal Agency for Healthcare Research and Quality. And what we found was really eye-popping. By a very conservative estimate, there are 830,000, more than 830,000 visits to hospital emergency rooms all over the country as of 2009, and the number's going up. That's a 16% increase from 2006, and at least 50,000 of those visits were for children. And why it's important to say that, to point this report out to this audience in particular, is that a lot of those visits are made by Medicaid enrollees or the uninsured, and taxpayers end up footing the bill. When you look underneath the surface at what those reports were actually saying, it's all bad news. I'm sorry to be the bearer of bad news, but it's just really bad news. In Washington, their study showed that the trip to the emergency room was the first dental visit for 25% of the children who were in emergency rooms. In Kansas, there were many thousands of visits, and for people in Maine, I think it was the biggest need among young adults. It wastes an enormous amount of money. In Florida alone, for the 115,000 ER visits that they have, it was a cost of $88 million. I want to reiterate that these were reports that have been done by state health policy institutes or other research organizations, so we did not do a survey. It wasn't standardized data. Minnesota, for instance, had a study which actually just gathered information from all the hospitals in one city. But what this is a symptom of a broken system. In case this wasn't clear, because many people who aren't oral health experts may not realize this, but there isn't dental care in hospitals. If you show up in an emergency room, the best people can do for you there is to give you an antibiotic if they think you have an infection, give you a prescription for a painkiller, and then say, go call a dentist. But if these people had dentists, they wouldn't have shown up in emergency rooms to begin with. So it's really the wrong care in the wrong place at the wrong time for people who are desperate and have nowhere else to go. And instead of a quick, effective visit to a dentist or a hygienist, you're ending up with an expensive visit that does not solve the problem for people. So why is this happening? First of all, we've got a very fragile financing structure in terms of dental in this country. There are way more people without dental insurance than there are without health insurance. It's more than a quarter of the people in this country lack any source of payment for dental. It's particularly acute among older people since Medicare does not include dental benefits. So all you baby boomers, when you turn 65, watch out. You're going to be without coverage. Another issue, of course, is that states are not required to provide dental coverage for Medicaid-eligible adults. About 10 do, but the rest do not. So anytime you hear a statistic about the numbers of people without health insurance, multiply it by maybe 2 or 3, and that's how many lack dental insurance. As I mentioned, the coverage for adult dental benefits is really very spotty, and since it's not a requirement, states change their policies every so often about what they cover, which has implications all the way down through their systems. Because if you are a clinic if you're a federally qualified health center, you have to accept all comers regardless of whether or not they can pay. And so when adult dental benefits evaporate, then clinics, FQHCs are scrambling to find other sources of revenue to pay for those services. And if you're a private provider and you had a family that you took care of, you don't want to all of a sudden say to that family, I'm sorry, I won't see you anymore. These are patients that the dentist is used to treating, and that's where the patients are used to going. So both the patients and the dentist feel burned. Another issue, of course, is that Medicaid, most states have challenges in paying sufficient rates for Medicaid providers, and that's true all across the system, not just for dental. But dentists have high overhead compared to many other kinds of providers. On the slide that I'm showing now, you'll see this green line that's about, a little more than halfway up. And what that is roughly the cost of what it costs dentists to provide the care. And the bars here represent sort of a composite measure of the rates for the 5 most common procedures. And so you'll see that most states basically don't even cover the costs of what it costs dentists to provide the services. So they basically feel like they're losing money on every patient that they see. Now, I think that's also true for other providers, and they go ahead and see Medicaid patients anyway. While I have great sympathy and believe that the Medicaid rates are an issue, there have been studies that showed that raising Medicaid rates does help, but it's not the only thing that states need to do if they would like to increase Medicaid participation and make sure that Medicaid-eligible people have a place to go for care. So one of the other issues is that there aren't enough dentists in this country. There's a huge shortage as well as a maldistribution. What this shows is the percentage of people in each state who are unserved. I don't mean underserved. That would be a different map. This is people who have no prayer of getting to a dentist. They are just too far away from any available dentist. So the darker the color of the state, the worse the shortages. So one thing that it's important for each of you to look at in your state is what percentage of your state's dentists are over 55, because in many states it's maybe 30%, 25, 30, 35%. So you've got sort of a cliff problem about to happen where in 5 or 10 years all those dentists are going to be retiring and there are not enough to replace them, particularly not enough who are willing to go to rural areas. So what can we do about all these problems that are causing people to show up in emergency rooms where we're basically not taking care of them and wasting millions of public dollars? One thing is to make sure that low-income children have dental sealants on their teeth. For those of you who don't know what a sealant is, because when I was young they didn't have these, dental sealants are clear plastic coatings that hygienists or dentists, or in some states dental assistants, apply to the molars, which are those big teeth in the back of your mouth. Those are the teeth that are most likely to get cavities, and so it's a really great preventive strategy. Unfortunately, the kids that are most in need and most likely to the kids that least need the sealants are the most likely to get them, and the ones who most need them are the least likely to get them. So if you're a Medicaid-eligible kid and you're in a state where only, 30% of the children got a dental visit in a year, you may not get a sealant. So there are programs in many areas to fix that problem and to send hygienists out to schools or teams of dentists and hygienists and assistants to make sure that those high-risk kids get sealants. But there aren't enough of them, and they don't get to as many kids as they should. They're extremely cost-effective since it costs a lot less to seal a tooth than it does to fill a cavity. One of the barriers to sealants is something that should be relatively easy to fix. It's not particularly controversial, and states are little by little realizing that their laws are outdated according to current science and moving to change them. But the Centers for Disease Control and the American Dental Association Council on Scientific Affairs looked at the issue of whether or not a dentist needs to examine a child before they get a sealant in one of these public programs, and the answer is no. Everybody agrees that a child should see a dentist, but it doesn't need to happen before a sealant is applied in a school-based program. So little by little, states are re-examining those laws and realizing that they're outdated and not evidence-based, and they're taking away that prior exam requirement. But as long as it's there, what it does is it adds a barrier, and it makes the cost of those programs higher, so you're serving fewer children. And if you look at where your state is here, you'll realize that the lighter the state, the two lighter colors are the ones that still need to change their rules, right? Okay. So this recommendation was supported by the Institute of Medicine report that I helped produce last year. The IOM recommended that state legislatures look at their state practice acts to make sure that they were up to date and were adjusted to maximize access to care rather than add unnecessary barriers. Another solution that a number of states are beginning to discuss is expanding the dental team. Medicine is way ahead of dental in this regard. And on the medical side, there are, I don't know, a dozen or more job titles, and it's more of a ladder where you've got dental assistants and medical assistants and lab techs all the way up through medical specialists. There's 3 or 4 or 5 kinds of mid-level providers on the medical side. On the dental side, all you've got are dentists and some dental specialists, dental hygienists, and dental assistants of various types, but that's it. So the states are beginning to examine a number of different types of providers which sort of fall into several categories. One is adding more training and services for dental assistants. Another is adding more training or services for dental hygienists. And a third type is a new type of provider here in the United States, but it's an international model called dental therapy. In this map, you'll see that some states already have new kinds of providers. Minnesota, in 2009, passed a law that established advanced dental therapists and dental therapists. Alaska already has dental therapists, although they have a slightly different name. And New Mexico passed a law establishing a new type of community health worker with dental skills that's called a community dental health coordinator. Another thing that you can do is to make sure all your water is fluoridated. Now, I know there are legislators that want to run screaming from the room when I mention the word fluoridation, because I've heard some really funny stories from legislators about hearings on this issue, in which they talk about the kinds of things that constituents say when they at hearings on this issue. But the science is clear and incontrovertible, and the track record over the last 70 years since we've been fluoridating water is crystal clear that it occurs naturally in water, and it just needs to be adjusted to the right level. What you're seeing here is the 2010 data on fluoridation, and the states with the lowest rates are the red states, and this is not a political commentary by any means. And the states with the best rates are the blue states. And then you've got, I think that's right. Yes, that's definitely right. So some of you have quite a bit of ground to make up, and that would be the thing that would save everyone the most money. It saves private insurers money in avoided restorations, and of course uninsured people. It helps all ages, and it's the single best thing you could probably do. The one thing that I did not mention about fluoridation is that the CDC data showed that for every $1 invested in fluoridation, it saves $38 in treatment costs. And it protects, it reduces decay. Actually, this is the most conservative estimate. The research shows that it reduces decay by anywhere from 25 to 40%. So that is, there's a number of cost-effective investments that I've mentioned. I'm open to your questions, and I really have appreciated the opportunity to talk. Thank you very much.
Thank you so much, Shelley. It's always interesting to see this. And I'm not satisfied with what we're doing in North Dakota, but I'm feeling pretty good about what we're doing here compared to some other folks. So we all have work to do. Now I would like to introduce Dr. Katja Moritzen. Dr. Moritzen is the director of the Oral Health Unit at the Colorado Department of Public Health and Environment. She received her Bachelor of Science degree in psychology at the College of William and Mary in Williamsburg, Virginia, and her doctorate of dental medicine from Tufts School of Dental Medicine in Boston. Dr. Moritzen completed a general practice dental residency at Brigham and Women's Hospital. Dr. Moritzen was born in Panama, and her commitment to underserved Latino populations brought her to Colorado as a student to work in Salud Family Health Centers. As a general dentist, she focused on delivering services to underserved pediatric and geriatric populations. Currently, Dr. Moritzen is pursuing her master's in public health with the Colorado School of Public Health. Please go ahead, Dr. Moritzen.
Thank you so much, Senator Lee, and thank you, everybody, for inviting me here. Thank you, NCSL. And I'm really happy to be here and to talk to you all as a new dental director to talk about the great tradition that we have in Colorado of oral health work. We're trying to pull up my slides here real quick, so I don't know if we have control. So I'll just get started and see where we're going with it. There we go. So hello again. So a quick background about what we talk about with children, what we're trying to prevent in children, and that's the cavities that happen. And the cavities are an infectious disease. And I apologize, we're having just a little issue with the slides here. Cavities are the most common chronic disease of childhood over asthma, and we actually have a great Colorado partner who's in foundation, and a lot of people are championing this message that we want to say we don't want to be number one anymore. We would love to say we're not number one. There are a lot of initiatives we've had in the past with foundations. We had Healthy Teeth, Happy Babies that one of our Delta Foundation helped fund, and it actually led to people, parents, getting into the dentist more and also changing behavior so that their children did see a decrease in cavities. Cavities are pretty much 100% preventable, and we know that good oral health, which dental health is part of that, is part of general overall health. You can't have good nutrition if your teeth are hurting, if you can't chew well, you can't speak, you can't smile, kids get low self-esteem, they'll go through kindergarten all the way through adulthood not smiling because they don't have good oral health. And we know that it's transmissible. There's kids up to age 2 are very susceptible to getting the bacteria that can cause cavities. So if a primary provider, if a parent is sharing spoons and cleaning the pacifier with their mouth, and that parent has a lot of untreated decay, that bacteria can then go to the kid's highly susceptible mouth, and they end up with a lot of problems. And I already mentioned that oral health is part of general health. So these are the issues that come up sometimes. It's not just cavities. It has caused deaths. And in 2007, in Maryland, it did a tooth abscess and wound up killing a 12-year-old boy after countless surgeries and a lot of hospital visits. This poor child wound up dying from a tooth that could have been treated. He didn't have access to a dentist that would see him. In 2011, it killed a 24-year-old healthy male in Ohio. And this man, as Shelley had mentioned, went to an ER, and in the ER, he did not get final treatment. He got antibiotics and pain meds, and that is it. So he was not able to go fill his both prescriptions because he didn't have good insurance coverage, so he only filled his pain medicine. So in the end, the tooth abscessed and went to his brain, and it killed him because he did not get his antibiotics. Next slide. And this is just what we look at in public health about what we need to look at is more than just the tooth. When we're looking at the child's tooth and the whole lifespan, we realize that there are a lot of levels that we have to work on. It's not just that tiny inset on the left where we look at the bacteria, the diet, the tooth, and we have to look at child level. We have to look and see that all of these things are being taken care of. So there's not one big magic bullet that we can use to take care of cavities and to keep kids out of pain. And many of those things that we've had success with in Colorado, Shelley had a map about it, that we do have hygienists that are able to do great preventive treatment. They're able to give sealants and fluoride varnish without a dentist having to do an exam. And our hygienists are also able in Colorado to directly bill Medicaid and CHP. So that's a huge barrier that Colorado has overcome. And we have a very robust dental loan repayment program. We have, in addition to the Health Service Corps that gets a lot of our dentists and hygienists into underserved areas, we also have a foundation-supported and private donor-supported robust dental loan repayment piece that these are for dentists and hygienists who don't qualify for Health Service Corps for whatever reason. They want to work part-time. They have a second program that they can get loan repayment. So, and that's growing every year. So our primary care office has worked a lot on this. And we know that family oral health is extremely important. We have local data that shows that if a parent goes to a dentist, the child is more likely to go, 1.7 times more likely to go to the dentist as well. And we also know that the health status of the parents is reflected in the child, and so is lack of insurance. And we in Colorado have some of the fastest growing rates of childhood poverty in the nation. We're third in the nation, about 350,000 of our children living under federal poverty line. So their parents can't afford to take time off from work. They can't afford to pay out of pocket for dental care, so it's a very big problem that we have to deal with. So I'm going to give you just a quick question that we might circle back on. And we have a couple questions just about which of the following provides the most effective benefits to oral health. And I'll come back to this at the end of the presentation, but just so you can think about it. Is it visiting the dentist twice a year, drinking fluoridated water, or is it brushing with fluoridated toothpaste? We'll come back to that. So the biggest thing that's going on in my daily work life and my unit's life and a lot of people around the state of Colorado is our winnable battles, and we chose 10 of them. These are key public health and environmental issues where progress can be made in the next 5 years. And we had a group of legislators, public health officials, data people, a lot of people who were interested in this when CDC chose their winnable battles, go to Atlanta at the CDC and listen and choose. We wound up choosing our own based on our local data, and oral health wound up being one of them. So our winnable battles are important because they have huge environmental and health impacts. They have large health disparities, and they affect certain populations a lot more than others, and it's a lower socioeconomic status and minorities. We have an ability to impact these areas because we have evidence-based interventions that really work. We just we haven't given access to the right people for those interventions. And there is a capacity in Colorado to impact these areas. We have partners and resources that meet this need. So our governor and our whole state has a special focus on 3 winnable battles: mental health, substance abuse, obesity, and oral health. So we're extremely excited about this. This is all the great work that's been going on in Colorado for decades, right? Finally reaching the tipping point that people understand the need and have the resources to make progress. And just to give you a little bit of context, in Colorado, mental health costs can cost my state about $1.3 billion in lost production. Obesity, the estimates are about $1.6 billion in healthcare costs. And we don't really have a good oral health estimate, but it's around $1 billion or more. This is what we're fighting against in children. So rampant decay, which is a ton of cavities. And again, what you're seeing is this is all 100% preventable. And when we look at a 3 or 4-year-old on that left side, this child is going to have to go to the OR, to the operating room, 1 or 2 times, be put under general anesthesia, go through some invasive, painful procedures in order to get those teeth fixed or pulled. And on the upper right, you could see a teenager, what it looks like. That child on the left is going to end up in the lifespan going to become a teenager with those adult teeth, and the very bottom's an adult. And so this is the progression through the lifespan of what goes on. And really, what chance does this child have of being successful in life? There's not just financial cost to the child of lost school time, lost work, and low self-esteem and pain and suffering, but an achievement gap because they can't sit still and learn in classrooms, but it also costs us a lot of money. And here's our beautiful maroon bells in Aspen, so you all should visit it whenever you get a chance. Just a little plug for our beautiful outdoors here. In Colorado, we have about 3,700 dentists and 3,300 dental hygienists, again, who are able to do a lot of preventive work. But so we don't really have a shortage of dentists right now. We just have them in the wrong places for the populations that need them the most. And we have a lot of, about 17 counties don't have a Medicaid provider for the dentist. And this is something that's a big problem that we're looking into. So we have a great initiative called Cavity Free at 3 that is starting to enroll dentists and door to door. They go office to office to enroll them in Medicaid so we can expand access. So that's a huge barrier, and we at the health department are creating a series of little podcasts and webinars that we are then going to disseminate to these new providers and also old providers to overcome any billing issues they might have with Medicaid. And when we talk about oral health through the lifespan, we're talking about gum disease, which is linked to a lot of chronic diseases, kids missing school hours. There's millions of hours that are missed, and the estimates are 52 million school hours per year over the nation. Parents miss about 164 million school hours, and this estimates are old, so we think it's even worse now. And there's a lifetime of disparities. And as you can see, there's insurance gaps that Shelley already talked about from their Pew studies. We just had one bill passed, which is old age pension benefits, which is now going to give $3 million to people over 60. So it's going to hit a lot of these 65-year-olds who do not have any insurance. And as you can see, Colorado adults over 65 do not really have insurance. And a lot of them have not had insurance over their lifespan. So they have a lot of needs that have to be met, or else we're going to be faced with a lot more OR visits, a lot more hospitalizations over time. And here you can see some of the economic impact at a local level just about hospital-based billing for Medicaid. Our hospital, Children's Hospital, they see about 3,000 cases a year of children going in for operating room dentistry. And each of those cases costs $10,000 to $12,000. So here's sorry for another gross picture. I hope you guys are done with your lunch already. But here we have, a lot of times in dentistry we talk about metal mouth. And really, we know what the answer is. Which metal mouth do you want in your child? This child on the left has been through years of pain and suffering, and this child has not reported pain in their mouth to their parents because from the moment they could speak, they've been uncomfortable and in pain. So when a child with this much decay that needed all of these caps and crowns put on her teeth, that child on the left has been in chronic pain for all of her life. So that is her normal. So when she actually points to a tooth and says, "Mommy, this hurts," "Daddy, this hurts," it's extreme pain. So our winnable battles metrics that we have, how are we going to know that we're making progress is we're going to look at age 1 dental visits. That child on the previous slide, if she had gone into the dentist by age 1 and the parents had been able to get some extra guidance, get motivational interviewing, to know how to change the behaviors and prevent those 100% preventable cavities from happening, we would not have seen that mouth at age 5. And that child would not have had to go to the operating room and put under general anesthesia. So, and I don't want you to worry if you haven't taken your kids to the dentist by age 1, because you're not the audience we're trying to meet. We're in public health. So if you're listening, the parents we need to give resources to are not listening. We're targeting high-risk, high-need children. And the other thing that was already spoken to in the first presentation was about sealants. This is the plastic coating that they get put on really highly susceptible spots of the tooth that usually get cavities in children. And if you have a sealant in there, you can't get a cavity in there. So that's why it's extremely effective. And then water fluoridation, as we talked about. There's the national that $1 saves $38 in investment in water fluoridation. But locally, we also have data that shows in Colorado, in a 2005 study, showed that $1 would save up to $61 in treatment. When you get a cavity when you're young, it's going to turn into a new filling eventually. All of us have had fillings that are broken, have turned, or know someone who then needed a root canal, a crown, then had to have that tooth yanked, and then if you have the money, you get an implant. All of those things over the lifetime of a tooth are out-of-pocket expenses for the person, for the most part, if they can afford it, and if not, they just go without teeth and they can't eat well, and all the other things can occur. Even with all the additional sources of fluoride that we get in toothpaste and in varnishes, community water fluoridation does prevent 25% of cavities, and up to, some studies show even up to 50%. Colorado has some rollback attempts. Sometimes we see a note that a town has decided to defluoridate because of an internet search, and they don't always come to the experts. They don't call the CDC. They don't call the health department to discuss things. So we're doing efforts where we're going to be training local public health and others to be able to speak to water fluoridation so we know it's safe and effective. And again, these are trends, and then the gaps were in the water fluoridation where we're rolling back. We're trying to increase all of these. Water fluoridation and sealants are proven evidence-based interventions. Fluoride varnish is emerging in older adults. We know that it helps prevent cavities, and it's emerging. It's really helpful for children, especially under 2 who have a ton of cavities. We know that they benefit if they get a certain number of varnishes. And we do a lot of work around social determinants of health to see that we can link then and have collaborations with other work, like in obesity and mental health, because a lot of those factors are the same factors that we have with others that cause cavities. They also cause obesity, and they also cause mental health issues. The other things that we do, again, I already mentioned cavity-free at 3, and this is all with our Winnable Battles efforts. We train not only general dentists, but also Cavity-Free at 3 has been training medical providers at the well-child visit to put the varnish on before age 2 so that we're really helping children not get as many cavities. And in Colorado in 2014, we could see 100 or 1,000 or more children getting coverage. So as we enroll more Medicaid providers, we'll be able to meet that need. We also have some efforts to train dentists how to manage seeing very young children in their practice. I never saw anyone under age 4 in my practice as a dentist, and we just don't have enough pediatric dentists. And then also how to treat pregnant women, so we can get pregnant women in before they become moms and give them evaluations and say, you know what, your child, because you have a history of cavities and because we can help you change your behavior so you don't put your child at risk. Our partners have worked on getting bills, trying to get bills passed to fund pregnant women with Medicaid benefits. And our Head Start partners have done quite a bit of work around motivational interviewing, which actually has been shown to change behaviors. And again, you do that with the populations that are most at risk. Here is a good list of some of our partners internally to the health department. This is everyone that we work with. We're integrating all of our work with each other, especially our priority internally is working on obesity, so we do collaborate with all of their efforts. We collaborate with self-management services who work with diabetes, because there is proof from a Kaiser study that came out recently that diabetics who get dental treatment utilize operating ERs, emergency rooms, and hospitals less. So it does become a cost saving within a few years. And we work with home visitation nurses as well to get training and to give public health interventions and varnish to children who need it at home. Here are some of our external partners that we have. Because of Winnable Battles, we work very closely with our Medicaid office, our Human Services office, Board of Health, and other agencies. And then we have a lot of great people at the table that we are working with. And nationally, we have some great partners. And you'll see, if you visit the American State and Territorial Dental Directors website, they have information on why state oral health programs are necessary. Because of all the things we've already talked about, the 20 states have statutes that require programs in public health and to sit in a public health agency. And about 36 states financially support their oral health units with some type of funding. An average of about 30% of their funding of oral health units can come from states and not federal. And that also ranges from 4% to 100% across the state. Our main funders for our oral health unit are the Center for Disease Control and Prevention and HRSA and in maternal child health as well. And there are some states that do have legislation that when you get into school, you get not just your audio and visual screening, but also dental. And that way you can catch some other problems in children that are getting into kindergarten before it becomes too bad. We have a collaborative that we work around with Winnable Battles, and these are a lot of the opportunities that we work with is legislation that passed in 2008, which was the Colorado Public Health Improvement Plan, oral health assessments at a local level. You know, people are supposed to look at that. Dental is also included in Medical Home Initiative. We're supposed to help establish dental homes, and we're all working and collaborating on that on a regular basis. Our maternal child health and one of our big funders, the Colorado Trust, has helped integrate dental oral health into the early childhood comprehensive systems. And this has led to a lot of great things that help us get at a local level a priority that is oral health, which is preventing cavities in children birthed at 5. And it also funded for the development of the toolkit for promoting maternal and child health, oral health in Colorado. And these are based on these lists of standards, and they're all pretty basic standards that everyone in oral health knows, but you could read through them. Water fluoridation is a big one. Dental home is a big one. Oral health education is provided everywhere we can go. And every person receives evidence-based interventions, and that we also have enough dental professionals to meet the need. And here's where you can find it, that toolkit. And again, we also are doing podcasts to overcome Medicaid submission barriers, and we're training home visitation nurses and motivational interviewing. This is cavity-free at 3 as well, and behavioral changing that will lead to prevention. Other states have done a lot of work with home visitation programs and have seen a lot of success with that. And this is one big study that came out of Colorado. It was at the time with the Department of Public Health with Tracy Anselmo, who was the dental director then, the Children's Dental Health Project, Dr. Bert Edelstein and Marcy Frost, and then Gary Hirsch, who is a system dynamic management consultant. And they basically looked at this ECC as early childhood caries. And they really wanted to see if there were some additional problem solving and decision making things they could do and levers that we could use in Colorado. And again, these are the types of things that we've used. Now, this is the interventions that we use. We have high stress, high cost interventions that do not prevent future problems. So fixing a cavity, it doesn't fix the lifetime of cavities. So we need to think about other things. This study that was funded by MCH HRSA looked at all of these lists of interventions. And really, they've used what's called a system dynamic approach to see what would work best. So what was needed was really evidence-based and risk-based guidance for families. Families needed to be engaged. They needed to be given counseling and the skills and the tools to be able to make behavioral change, and they needed action planning. And this is the framework that the study came up with. And you might have heard a lot of times people talk about risk-based assessments and for dental benefits. And this is one of the reasons, because of this study. And And you can tell that if states that are paying for the motivational interviewing piece of with Medicaid or with other dental benefits, they tend to see a lot more behavioral change and therefore a lot better results and outcomes. So we're going to circle back to the big question in the quiz, and the answer is what was considered one of the top 10 public health interventions of the 20th century. Drinking fluoridated water on a regular basis is more effective than visiting dentists twice a year and brushing with fluoridated toothpaste for oral health. And if you brush your teeth without fluoridated toothpaste, it still does help quite a bit. And seeing your dentist helps. Please don't say that I told you not to go or not to brush your teeth, but the fluoridated water is the best cost-effective and safest way to go. So thank you so much for your time, and I just think it's time for questions.
Thank you. It would really help if I took the microphone off mute, wouldn't it? Anyway, I really want to thank Dr. Moritzen for her comments, and congratulations on all of the good work that's being done in Colorado. That's very encouraging to the rest of us who might be able to learn from those experiences you've shared. And so I'd like to thank both of our speakers today, Shelley Geshen and Dr. Katja Moritzen. One thing that occurred to me as we were talking about care, excuse me, was we were saying if someone didn't have insurance, they weren't necessarily going to get dental care. And I think it's really important not to ignore the fact that a lot of people are in a position to pay for their own dental care and choose not to have insurance but still choose to have dental care. So there is a third category there. It doesn't mean that people aren't receiving care because they don't have insurance. I understand all the issues with people who don't have the money to do it, but dental insurance is a pretty new thing comparatively speaking. When my kids had braces, the same month that they came off, my older child was the same week actually that we started going to the dentist for my younger child, and we just made monthly payments for a fairly long period of time. So I think there are a lot of people who do choose to take care of their own dental coverage costs because dental insurance is expensive if it's really comprehensive. So as is true of everything else, there ain't no free lunch. Anyway, that having been said, I think that we should move on to Jennifer for our question and answer portion of the webinar. Jennifer, there you go.
Great. Thank you all so much for the great presentations today, and thank you so much, Senator Lee, for moderating the webinar. Now we'd like to open the floor for participant Q&A. Please type questions into the chat box on the lower right-hand corner of your screen. If you don't see this chat box, then please click on the orange arrow on the right side of your screen, and then it will pop up. And remember that your questions will remain anonymous. Also, just an FYI, I have received quite a few questions, so if we don't get to yours, we'll do our best to get back to you later and give you an answer. So first, I will start with one question for Colorado. Do you provide preventive dental coverage for pregnant women in Medicaid? If so, how do you get key stakeholders to provide given all the state budget issues and cutback in services?
So this year that was legislation that was proposed. However, it did not pass. So we expect that our partners will be revisiting that with the next legislative session. I can't speak to some of the details of it, but there are a lot of people in our state that can, so we can always put you in touch with them if you have quite specific questions.
All right. Also, can you describe motivational interviewing, and then can you get Medicaid to pay for motivational interviewing?
That's something, honestly, I don't know about the reimbursement of it. Motivational interviewing in oral health and dentistry is emerging. That's something that we're looking at locally with Head Start, so that is something that Head Start does. And we're hoping as we get more information and more data on it, we're going to be able to disseminate that information and then have it be more widespread. It is very time intensive. It requires, what happens is a child and their primary care providers come into the dental clinic. They get a big risk assessment, which includes not just their the child's mouth and looking in the mouth, but it's also how many cavities does your mom or dad have, or your primary care provider? How many cavities have your siblings had in the last couple of years? If you say yes to a lot of the questions, then that child is high risk, and therefore they get intensive guidance, and it's called anticipatory guidance, that they are given the skills and they're taught what type of things they can do and behavioral changes they can make to avoid having to send their child to the operating room. So it involves the primary care providers that they're in the dental chair, learning what they can do differently. And but again, it's very time intensive.
Another question, what is the most effective way to educate adults on the risks of poor dental care and risks of stroke, any sort of systematic infections?
That also is one-on-one contact quite a bit. When we also need to make sure that our providers have the resources that they can give to people who are at higher risk. We can't disseminate information. We can't tell everybody everything. So we have to look at risks of our patients, of our populations, and then teach our providers and give them fact sheets, but also give them, sometimes if you're able to give counseling that is reimbursed, then in a dental practice you're going to be able to get more one-on-one counseling from a hygienist or from a dentist in order to be able to avoid risk for other comorbidities.
Great. And I'm not sure if Dr. Moritzen or Shelley can answer this one. Well, I guess Dr. Moritzen for this one. What data from Colorado and their increased access to dental hygienists can we use to show the benefits of such scope of practice expansions in other states?
And we have, with our winnable battles, we do have a website that you could just search on the internet, Colorado Winnable Battles. You can also go to our website, which is called coprevent.org, and you can see the trend data that as we are increasing sealants in the children that have the highest risk, which are the lower socioeconomic status children in Colorado, we are seeing a decrease in cavities. And we don't have released our current surveillance and our current data, but that's going to be up in the next 4 months. So check back in the next 4 months, and we're going to have trend data that could be used and might be helpful for other states to look at when they're considering what moves they want to make.
Great. Would increases in reimbursement rates necessarily improve access, and should limited financial resources be targeted at those who mainly provide services for Medicaid patients? Yeah, Shelley, do you want to take a stab at this one?
Sure. There is some research on whether or not raising Medicaid reimbursement rates improves access to dental care, and it's somewhat of a mixed picture. There's data from 5 or 6 states, and in most of them, it does cause more dentists to participate, and they tend to have a few more children in their practices, and they do a few more services, but it doesn't go very far towards fixing the problem. There are other more innovative approaches that some states have chosen. Like Rhode Island, for instance, got a Medicaid 1115 waiver to pay more on the prevention and on the assumption that it would save money down the line and reduced restorative costs. Some states have just started paying as much as commercial payers do. I mean, the Michigan Healthy Kids program has done that, and Connecticut raised their rates, and they have gotten some pretty big increases in utilization. The hard thing is sustaining that over time, because it's actually really hard to keep it up, because dentists tend to get busy and they come in and out of the program a fair amount.
Great. Just scrolling down for the next question here, sorry. What amount of the award that goes toward loan forgiveness does the state provide direct appropriation for this program? Does anybody know the answer to that?
You know, I can say something about that a little bit from the national picture because I did a study on that some years ago. And basically there's two approaches. One is that there's federal money through the National Health Service Corps that is administered by state, usually by state rural health offices. And that is almost all federal dollars for loan repayment. And then there are states that actually put their own money in. And so I think your question is what percentage goes to the individual, and I think it all does. I mean, states are supposed to actually just put their own money into the staff cost to administer those. My data is old, though, so it could be a different picture.
Yes, and then I mentioned in Colorado we do have private foundations and also individuals who actually contribute to this as well. So we're very lucky.
Another question, reimbursement is an issue, but so is the unreliability of Medicaid patients keeping appointments. Have states have better luck with first come, first serve?
There are several different models, and one of the concerns that Cavity Free at 3 has heard when they've been doing interviews across Colorado as to why dentists are not accepting Medicaid is that reason. And they also don't know that when you do enroll with Medicaid that you can decide to only take a certain number of patients. So there are just knowing that and then also setting guidelines on the practice level and making sure that when you set up appointments that you schedule in ways that you're comfortable with are things that we're trying to talk to providers about so that they feel more comfortable just taking that first step and enrolling in Medicaid. But that is a concern that does come up. But you know, and it might happen more often in certain populations. However, we're trying to address that barrier. I don't know what other states have done successfully for that, but Cavity Free at 3, we'll be able to have some data in the next year or two to really show how those efforts have worked. So we will share that with you.
This is Shelley. I have another thought or two about the Medicaid patient issue, and that is that there different states have handled that in different ways. There are some clinics or practices where they double book patients, and they do an awful lot of reminder calls. There's a clinic called the Sorrell Dental Clinic in Alabama that has a whole phone bank that does nothing but talk to patients and make sure they can get to care, and they remember to come, and they remind them, and they keep them coming back in for their reminder for their subsequent visits. And there are some states that have permitted dentists to do Medicaid days, so because they have concerns sometimes about whether or not they want Medicaid patients mixing with their private pay patients, so they just put them all on one day. So there have been a number of different approaches to handling that issue.
Great. For either of the speakers, are there suggestions to overcome the barriers to sealants?
Well, this is Shelley. I will just say one small thing, because I'm not, Katya would know a lot more about how to administer one of those programs, and that is that we're, the Center for Medicare and Medicaid Services is just now, has just now begun to collect data from all states about how many kids actually get sealants in states. There has been national data that's reported to the CDC from states, but not all states can afford to repeat that every year. So it's hard to even know how many children have sealants. So we're not really sure what we've got, and we're going to keep that up. But there are a lot of barriers with respect to dentists not being clear that it's really what they should do. Not all of them agree with or follow the evidence. And there are also reimbursement incentives that may work the wrong way.
And this is Katya. So sealants work best, especially in schools that have about 50% free and reduced lunch children. That's where we see the most bang for the buck. But because the number one thing for us is because hygienists can place the sealants without having an exam, they're able to use within the scope of practice, say this tooth does not have a cavity, therefore I can put a sealant on it before the child sees a dentist. That's a huge thing that is very helpful. And working with school systems, our providers that give sealants do it on an individual basis. Some other states do statewide sealant programs where they cast a very wide net. So every child gets the sealant that if their parent gives them consent. And that cast that wide net does encompass the children that need it the most. So there are different strategies that different states use, and really for us, the fact that we can have hygienists going into the schools has allowed us to see quite a few more children getting the preventive care that they need.
All right. Are you, either of the presenters, are you aware of any successful case management programs or strategies?
This is Katya. I mean, really with us, it's Head Start that have done quite a bit of things, and that they're quite successful. And I'm sure there's others in Colorado, so I apologize for my Colorado partners. I'm just too green and new to know to be able to rattle off the list of everything else, but Head Start has done that quite successfully.
Did you have any ideas, Shelley, on that one?
Nope. That's not something I can add to.
All right. Dentists don't have enough time to see everyone, but if there's a resistance to mid-level providers, I'm sorry, I'm not reading this correctly. Senator Lee, did you have a question?
Back to getting my mic on. I looked back at this and realized I deleted a couple of words and sort of messed you up. But what I intended to say was that dentists don't have enough time to see everyone. And so not only are we going to be short of dentists for a variety of other reasons, but it's just there aren't enough bodies to go around. And we can't make them go into low population areas where the services are most needed. But dentists as a group have, in many cases, resisted the participation of mid-level providers. I don't mean dental hygienists because I view them as being comparable to a 2-year nurse. I'm talking about someone who would be equivalent to a nurse practitioner or a physician's assistant and would be providing high-level, mid-level care. So how can states, in the view of the speakers here, what can states do to be able to work, not certainly in opposition to dentists, but to encourage dentists to view mid-level, high-level practitioners as partners in providing care in the same fashion as physicians now recognize the value of nurse practitioners in providing care in order to broaden our coverage?
Well, I can take this one. This is Shelley. I think it's a great question, and I think there are a couple different things. In the states where we work, we don't push any particular solution, and we look at what the we gather data. We usually hire like a objective researcher or university to gather data about the need in a state, and then we work with a group of stakeholders, including dentists and dental associations and other associations and provider groups, to figure out what the right solutions are for that state. And you know, dentists have to be at the table and part of the solution, and they have to get correct information. There's a lot of misinformation out there, so people think that the sky might be falling and it might be the end of private practice as they know it, and that's very far from the case. I also think that the economic case has to be made a little better, and there needs to be more research on that. We published a report, I think the beginning of last year, called It Takes a Team, which was an economic model that individual practitioners could use to figure out how a new provider would impact their practice. and it basically showed that dentists could they could make Medicaid rates work and benefit economically by hiring new types of providers in their practices. So I think it's really, the same arguments were made against hygienists 100 years ago as dental groups are making now about new mid-levels. And so we have to reassure them and work with them and gather as much information as we can and move forward together.
Great. Another question. What is your thought on some preschool settings promoting not rinsing after toothbrushing? Is the practice promoted by the dental program?
This is Katya, and I'm sorry, I'm just going to reread the question of not rinsing after toothbrushing. I think, and I assume that's so that they still have the fluoride on their tooth, in their mouth. The reason why in my question and for the quiz that fluoridated toothpaste, brushing with fluoridated toothpaste isn't as protective as drinking fluoridated water on a regular basis is that the lasting effects of that fluoridation don't last that long. And when you drink water, though, your saliva is much less likely to allow bacteria to grow and cause cavities because bacteria cause acid that eat away at the teeth. And a fluoridated toothpaste might help while it's in the mouth. If you rinse with water, then it takes away that fluoride. But I don't know of the programs that do that. I think that it's really a matter of understanding that when you don't have acid growing in your mouth because you have good water fluoridation and your mouth isn't acidic, then you're a lot less likely to have cavities. So I'm sorry I can't speak more specifically to that program or that suggestion, but we'll go on to the next question.
Great. Are there more strategies that you recommend to getting more dentists in to see Medicaid patients? And what do you say when you visit them? Are you seeing results? If you want to expand on that information that you presented, that'd be great.
And this is Katya again. So our big partner that I've mentioned several times, Cavity Free at 3, they just are starting at this new initiative that was based on a Colorado medical model where basically one pediatrician went door to door enrolling general medical doctors into Medicaid one at a time. The strategies they are doing is they're doing input meetings. They're asking what the barriers are, and then we at the state health department are making the podcast to help them overcome some of the billing and interaction with the Medicaid billing software, those barriers. Cavity Free at 3 also has developed something called the Dental Calculator, and that's going to be launched next month. And they actually show that if you, as a general private dentist, have empty chairs, that if you have an empty chair, you're losing money because you're paying rent, you're paying staff, you're paying for insurance for your staff, you're taking care of your small business. And if you input some numbers, they have created this calculator that shows if you just would accept one Medicaid patient a day, how that would impact and be profitable for your practice. And that's very impactful when you can go to someone and say, listen, not only can you help your community by helping the children who get Medicaid in your community, because we really only have true dental benefits from children in Colorado. We do have some emergency adult benefits, but not much. So when you can show that, then you're going to have an impact and have more people hopefully enroll. So when we get that data, we'll share that with everybody. And we expect, and it has already one-on-one, had more people really look at Medicaid and start to enroll. So we're very excited about Cavity Free at 3's initiatives.
Great. Shelley, did you have any ideas there?
No, that was a good one.
Great. Just one final question. Katya, do you have additional information or resources that you could point the participants toward about motivational interviewing and Head Start programs?
Yes, and if there's opportunities, we can even put together a resource page. You can just search it as well. There's a lot of places in California that have also used motivational interviewing. And again, it does take time. However, it might cost time up front, but it saves a lot in cost and in pain of the operating room dentistry that we've been doing as something that unfortunately is becoming a standard for a lot of children in Colorado. So being able to do the motivational interviewing, we can get together some resources and share those with you all when we send out the webinar links later.
We can definitely include that on the webinar webpage, which you'll see on the screen. And if anybody has additional questions or information they'd like, this is Jennifer Wheeler. My email is also available on the screen. I'm going to go ahead and wrap us up and just say thank you once again to all of our wonderful speakers and to Senator Lee for moderating the webinar today. And thank you all for participating. We also want to thank the Pew Children's Dental Campaign one more time for their support. Please be sure to give us feedback on the webinar by filling out the survey that will appear on your screen when you close out of the webinar. We really appreciate your input. And as a reminder, you can find the webinar slides and an archive of the webinar on our website starting next week. The website that's listed up here on the screen currently, if you want to listen to it again or if you'd like to recommend it for others. So thank you all very much and have a wonderful Friday.
Thank you.